So Dr. Etches, if you'll kick off the discussion with us, let me ask you, how is data being used presently to inform policy of importance to the public in infection prevention and control measures, such as closing and opening public spaces, stores, schools? What are the roles of provincial and local authorities in making those decisions? What's your role in relation to those decision makers?
Thank you for the questions. And I think before I can talk a little bit more about how we're using data in some of those decisions, I also think I should probably just go and provide a little bit more context in terms of where we've come from and what we've had to do in this pandemic to create new sources of data. So the local public health unit that I lead is responsible for understanding the health of the local jurisdiction, so in this case, Ottawa. And in order to do that, we typically draw on different kinds of data. We typically use surveys, and we have used the Canadian Community Health Survey, as a reference point for some things we're interested in about the health of the population, say, questions around mental health and some of the impacts we've drawn and use some of those questions to do surveys. We also use administrative data, so that would be information that's collected as people are accessing health services, and so in this case, things like hospitalization data. And I can tell you we had to strengthen our direct access to some of that data because we didn't used to get data directly from the hospitals, and so we've been able to create new extracts and improve that. We also use data from our own operations, and in this case, a lot of it, you can imagine, is either related to outbreak investigations or following up with someone who's tested positive and their contacts, that kind of also, investigation data. A lot of this is COVID heavy. It's about the virus, and we know that's not the only thing that's important to the health of the population. And so we also had to create new ways to go out and think about other impacts on the health of the population right now, such as how people's income's been impacted, how their employment's been impacted, again, using more of a survey approach. So from the beginning, we're very committed to making this available to the public, and it's continued to evolve. So right now, what we're using is a dashboard on our website, and again, we try to promote it, tweet different links, to it, and make it, something that people can digest. We've certainly sought feedback about how we're presenting data over time, and we've modified the visuals and tried to make it clearer. I can get into more of that, but just to say, we actually had to create a whole new database for our work. So the database that was used usually for infectious diseases just wasn't sufficient for rapid response and to collect some of the variables we were interested in. Socio-demographic variables like information about racialized communities and background was desired. So all of these things have been newly created, and we continue to adapt. So to get to your question about how do we use this to inform policy and decisions, I think what's important is we need to look at more than one piece of information at once. And so the question you asked me is about now, but it relates to the reopening, or getting past when everything was shut down and moving ahead. And now we're almost into, well, do we need to go backwards? We used a framework to capture the dimensions that the province said was important to them. So the role of the province is to take a look at beyond just our little jurisdiction, what's happening across the province, and they're the ones that have the regulatory authority to use emergency powers and regulation to create new guidance and impact some of these things you mentioned, like what is open and what is required by law. And so we used the provincial framework, which was to take a look at, well, what's happening with the infection, are the number of people testing positive increasing? What's happening with the health system capacity in terms of hospitalization, hospital capacity? What's happening with our public health system's capacity to respond, in terms of timely follow-up? And what's happening with our testing system to be able to detect the virus? The provincial framework doesn't have some other elements related to the state of the economy and those kinds of things. So we bring those into our thinking. But those are some of the monitoring indicators on our dashboard. And so we look at trends. So one specific number on its own and one dimension on its own isn't enough for us to say, things need to change right now. But we need to look at, even within the numbers, within one category, like the number of people testing positive is growing. It's more concerning if it's older people who are more likely to have more serious illness compared to younger people. So we're looking underneath at trends again in the ages and that kind of thing. So I think the decisions right now, people are concerned that the level of outbreaks, has tripled in the last month. The number of hospitalizations has doubled recently. We're starting to see, challenges for sure around hospital capacity. And so a lot of the measures show stress and strain, and the way we're using to communicate is a color-coded system to try to give that overall picture. So we actually did just move on a 4-color scale into the worst color, red, and that was intended to try to convey, well, there's all this number, like what does it mean? And so then when it comes to, well, we're red, what do? We need to do something. How do we turn the curve again? Those are the policy decisions about, well, where can we address the risk? And so it's not just about our own data. We have to look to the literature about what do we know leads to transmission of COVID. And then a lot of what we're using is our own information from our own investigations of people who test positive and where have they been, what are the exposures, and there are limits to this data. People don't always remember what they were doing the 14 days before they tested positive. People have multiple different exposures, so we can't pin it on one thing. And so we put together what are the environments that we know from the literature and the kind of behavior that leads to transmission with what we're seeing in terms of the start of outbreaks and these kinds of things to try to be more targeted around the measures that then need to be implemented. So we provided advice to the provincial government about what we're seeing, what's causing transmission in our area. And we definitely have underlined, and for the public too, that it's about our gatherings, right? Our social gatherings with others in close contact without masks. And so the measures then we're trying to target are decisions to adjust what, and point to and highlight what we need to change around where we connect socially in close quarters without masks. And so we saw the province take some decisions then around closing restaurants, bars, not closing, but shifting them to takeout, I guess. And we know that those are hard decisions to make because the government is interested in not just COVID, but also the health of the economy and businesses and people's health, which is in fact affected by such actions. So I hope that answers your question, and I'm happy to elaborate on anything.
Thank you. I think that's a great start. So we may come back to some of those themes in the discussion, but what I'll do now is turn to Dr. Forster and ask, how is data being used to decide on hospital policies about, for example, who gets to visit and for how long, in what number, on what terms, which types of patients can receive visitors? And this is something that has fluctuated over time, I think. How do you decide on what elective procedures are going to be prioritized or stopped? how is testing, decisions around testing being made?
Great. So just in general, I'll just start with why we measure things in the hospital sector. Really we do so for monitoring disease activity or even the activity of our operations. So counting the number of cases or counting the number of procedures we're doing. Ultimately, we do that so that we can track against historical patterns and make decisions about whether we need to invest in certain areas or not. And so that's sort of a monitoring function, which is really critical. A second reason we measure is really and monitor, or sorry, we track data is really around evaluating the impact of various factors which may come into play. So, for example, if we change policies, what is the impact on the policy, both in terms of the outcomes we're wanting to see or the activity. And then the last reason we track data is really around predictions. So we can hopefully predict the future to a certain extent and use that data to then make decisions that would hopefully, either allow us to account for what's going to happen in the future, or if possible, shape the future to something more favorable. And so those are kind of three big reasons why, and you gave some specific use cases, around visitor policies and surgical activity, and then around testing. And I'll just speak to a few of those. So when it comes to the visitor policy, really that's about the monitoring function, really, as opposed to much more of anything else. And for that, we're really working very closely with the public health unit and sort of what's happening in the broader community, because when it comes to visitors, what our big concern is that the visitors either bring in the disease or they come in and acquire it in our institution and then take it out. And really that would be two sort of things that we would want to mitigate. So really for the prediction on that, it is the level of community spread that is the risk factor. So really looking closely at what's happening in the broader community, and taking sort of measure of what's happening from measures outside of the hospital is very critical for that. And so we're really tracking, along with Vera, the numbers of cases in the community, the numbers of outbreaks in facilities, and using those data to guide it. On the surgical activity, and that you asked about that. What are we doing there? And really, this is actually one area where I feel our communities come together quite nicely. There has been this in the past, and we can talk about later, but healthcare, while most people in the public would say healthcare is one entity, in reality it's many different entities, and we're all different, essentially, corporations who have responsibilities, one of which is looking after our data and making sure patient privacy is protected. But ultimately that does impede our ability to share data on what we're doing and how we're doing it. And so when we're talking about trying to create an access program for surgical activity across our region, we do need to actually work very closely with other hospitals, other healthcare facilities, and make sure that we have a common view as to the activity we're doing, and then make decisions about whether we need to reallocate sort of certain types of care to certain types of facilities. Like, so for example, from the Ottawa Hospital, we've recently moved some of our elective orthopedic surgery to community-based partners, as an example. And so really what we're doing there is evaluating, and coupled in with that is we have some ability to predict what operating room capacity is required. We then work with the surgeons and others to determine what is the right level of care that we need to move forward with. And to a certain extent, there's prioritization schemes, but on the other hand, there's also a piece of this which is the clinical art, and we really do need to work closely with the clinicians so that they understand where the opportunities are for the care based on the data, and then we understand where the need is based on their presentation of patients. The last piece is around the evaluation of impact, which I talked about, and I'll use the testing on that one. We've known over many months that testing has been a challenge. It's been really basically right from the start, and yet we know also that unless we manage the demand somehow, we're never going to have enough capacity for this. And so really, it's about how do we match up our capacity to where the demand is in our community. And I would say we've got to get that like, this is really, again, getting into the realm of public communication, but there are ways in which we can use data to inform the decision. So one of them is to look at the prevalence, the probability of a test being positive in the samples that we're receiving. And we know that certain populations, if we look at certain risk factors, those will predict they'll have a higher test positivity rate than in other groups. And so using that as a surrogate marker for the appropriateness of our testing capacity, but also of how we're matching that capacity to the demand, is one way in which we can guide decisions about when we need to enhance testing in a particular group or not. So those are just kind of 3 examples. I'm happy to dig more. There's a lot of details behind what I've spoken to, but I think just keeping it at a high level of basically the monitoring disease and activity, trying to predict the future and use those predictions to guide our policies and decisions, but then also evaluating impact and making decisions based on that evaluation so that we can inform based on evidence moving forward.
Thank you so much. I do have follow-up questions. I will come back to both of you, actually. They're jotted down here. But let me turn now to Dr. Deonandan and give him a question, and then we can launch into a bit more of a discussion. So, to Dr. Deonandan, what are the challenges in communicating uncertainty about the data to the public, and also about explaining changes in the policy as the pandemic evolves?
Okay, first of all, you can see my virtual background, I assume, and it's there not to make you wistful for a time when we could all congregate intimately, but to remind you that it's actually a good thing to be home because we don't have to push past hundreds of sweaty bodies to get to the bathroom. These are good times. We should celebrate these good times. And I think we all accept that we're probably in something of a public health communications crisis, and we can talk more about that. I do want to say the extent to which any public health unit is doing a good job of this, I think Ottawa does a very good job. So congratulations to Dr. Etches for having a really good communications team. The social media feed is particularly fun. And I'm not being sycophantic there. I think it really is quite good. So, but to answer your question directly, we have an epidemic of distrust, and it's compounded by, I think, the dividends of decades of ignoring science literacy. That's really not helping our cause much. And many of the public see science as like the cabal of high priests with the right answers, and don't understand that science is an evolving process that is supposed to respond to improved evidence. So when there are midstream changes, like saying masks don't work 1 week, and then a couple of weeks later saying everybody should wear a mask, that breeds distrust in a certain segment of the population. And wrapped up in the distrust is the particular social infection of our time in history. Beginning, I think, with the 2016 US election, this thing called fake news, where suddenly any narrative that does not adhere to my personal beliefs or doesn't make me feel good inside is propaganda by the elite class. That's not helping either. So we're combating poor science literacy, we're combating naive misinformation, and active disinformation that's propagated intentionally from certain political circles. So we can theorize about it if you like. But one of the biggest challenges, I think, is that science is hard. Science is complex. And proper science is processed through this boring thing called peer review, right? Who reads peer-reviewed papers? Other scientists. And even then, we don't read them that carefully or that often or with that much passion. But the counter-narrative, the anti-science narrative, the COVID denial, as it were, the pseudoscience narrative is presented as YouTube clips or as Facebook posts or as memes. And that stuff gets a much faster and deeper penetration. It's more shareable, it's more easily understood. The counter narrative is better packaged than the scientific narrative. So the challenges are, if I could, I think 4 or 5. 1, we are fighting a tsunami of misinformation and active disinformation. 2, we cannot appeal to the innate science literacy of the population because there isn't much of it out there. I think the Australian study came out this week showing that the virus lives for many hours, if not days, on certain surfaces, and suddenly people are going crazy. And I have to point out that the lab experience doesn't necessarily translate to real life, this thing called external validity. And I think a lot of people just assume that people understood that innately, but people don't understand that innately, right? So had we invested more in the fundamentals of science literacy, the idea of external validity would already be percolating out in there, and that wouldn't be the job of science communicators to push it further. Third thing is that science is harder to sell than non-truth. So truth in science in particular is harder to sell than non-truth because it's more complicated. Fourth thing is that true science pivots in response to new data. But that pivoting compromises the believability, the authenticity, the authority of the supposed experts in the minds of a sufficiently large contingent of the population. So the more genuine we become as science communicators, the more transparent we are, the more honest we are, the more compromised we become as tellers of actionable information in some circles. Lastly, though, I want to talk about something involving the ethics of public health communication to make it relevant to this format, I think. We don't talk about the ethics of public health communication much. Often what we're trying to do when deploying public health messaging tools is to enact behavioral change through that messaging. I'm going to make, here is an evil picture, an ugly picture of a diseased lung. I want you to stop smoking, right? We're trying to change people's behaviors through the messaging. But that is a paternalistic goal. It's essentially saying, I know what's best for you, and I will pull all the levers that I have to coerce you and compel you to behave in a way that I think is best for you. So perhaps a more ethical goal in a liberal democracy is complete transparency. The assumption being that if we empower the citizens with appropriate and true information, they will reach the same conclusions that we have made and will choose to behave in a way that is supportive of our public health endeavors. This is obviously a naive position because it's very possible that many people will choose undesirable behaviors even when they are well informed. So what do you do then? What do you do when not enough people, when a sufficient number of people are still choosing to discard the science even though they understand the science? So this is when public health ethics comes into conflict with liberal democratic ethics. And I don't know what to do at that point. So those are the challenges, and they are enormous. Right now, we are fighting not just a pandemic of a virus. We're fighting an epidemic of mistruth, of misinformation, of disinformation, and we're losing that fight, I think. Gloomy message, Ray. That's my answer.
Wow. Okay. Thank you. Thank you. Thank you. I want to pick up on this theme of masks and sort of frame this as maybe like an unavoidable tension in trying to communicate with the public, and that is that this is actually any decision, advice that's going to be given is going to be the product of a very, very complex series of considerations and trade-offs. And if one tries to be fully transparent, people are going to have to read a 20-page paper to justifying the recommended public health advice. So is there an inescapable tension between transparency, information, and comprehensibility? Do you snow people under? And I'm thinking about masks in particular at the outset. There were a number of reasons sort of affecting that advice, concern about a run on masks and reserving it for people who are at greater risk, contested advice about whether it was needed or beneficial, or would it actually be counterproductive. And this changed over time, but different locations took different approaches. It might be helpful, but watch out, don't use it improperly. It might be counterproductive. Others said, let's just tell people, it won't help you, you don't need it. And then when it changes over time, people start to worry about that. But is that part of the problem of trying to communicate really complicated trade-offs under uncertainty over time? You can't give like a fully detailed sort of elaboration of the thinking behind.
I'll take a shot at this if you don't mind. Yeah, that is the essence of the problem, is how much do you distill the science to make it understandable, yet not obfuscating at the same time, right? So the challenge of science communication is making something understandable, but not overly simplistic, that you lose the magic and the majesty of science, which is complexity.
Mhm.
And so the challenge around masks too is that there is a core contingent of people who are going to resist it no matter what you do. And somehow it's built into their DNA to be anti-authoritarian. And it's sort of like if the people they don't like were saying don't wear a mask, they will probably run to wear masks. And the people they do like are saying don't wear a mask, and they would run to say, you know what I'm saying, right? So how do you combat that that innate desire to fight the anti-author to be anti-authoritarian? I don't know. I think one thing we can push though is the precautionary principle. That seems to be a tack taken by the climate change people as well, right? Because there's a core contingent of people who are going to be climate change deniers. And the precautionary principle simply says that what is the cost of not doing it and what is the cost of doing it? And the cost of not doing it can be enormous, and the cost of doing it is actually quite small. So when placed in economic terms like that, I think a lot of people can get it at that point, but we have failed to actually put it in those terms.
It's Vera, if I don't mind, if you don't mind me jumping in as
Please
well.
do.
I want to go back to a point that was made just a moment ago in terms of empowering people to make their own decisions. And this is something we do strive for at Ottawa Public Health. We want to be informed by what people think and actually understand. So one of the ways we tried to get at promoting mask use was to ask the population through an online engagement platform called Engage Ottawa, about, it's voluntary, so it's not always representative, and we can do surveys to get more representative data, which we do, about the proportion actually using a mask in indoor places. We do those too. But we found in July that we asked, why would you be against wearing a mask in an indoor place? We wanted to understand that. And people say, well, it's either difficult to talk or breathe. I think we've all had that experience. Yes. They said they might have a medical reason not to wear one, and that we respect. Or they felt that maybe masks provide a false sense of security, or they just would rather stay 2 meters away from people than, have to wear a mask. Those are all pretty reasonable answers for why you wouldn't want to wear a mask, and they're not all harmful. Right? Some of those are totally acceptable. And so it allows us to, to be empathetic and to support that and engaging like this and doing the surveys shows us it's a minority of people who say they wouldn't support wearing a mask indoors. And we find out, why would you like to wear a mask? And people said, well, they're scientifically proven to be effective at reducing the spread of COVID-19. They know that. There's science out there that shows that, and the science gets stronger all the time. People say, well, masks are an easy way to protect others. It's easy. It's not a big thing to ask. It's something doable. And then also, people told us a mask bylaw would normalize the use of masks for those who feel like a little less confident or a little less comfortable going out and trying something new. It helps normalize it and make it certainly something that's taken up more. And I would say it was very interesting to see the feedback once we went from something voluntary to a mandatory mask bylaw, except for those who have medical conditions. People said, oh, it helped me remember. It helped me remember to keep a mask in my bag or in the car or at home, like by the door, so that when I went out, then I actually had one. And so I think the other thing we've learned, from literature about behavior changes, people do respond better to encouragement and positive feedback about how they're contributing and helping others. And so I think this is also part of how we've tried to speak about mask use. Right, that your mask protects you, me, and my mask protects you, and some of these things we saw were effective in communicating.
Can I ask a follow-up about that? The idea that masks are an expression of altruism, that they protect the other as opposed to you. Is there an inconsistency in the messaging to say that masks are really necessary for people, for example, who are frontline treating people who are infected, or who have someone at home who has an infection and are being encouraged to wear masks to protect themselves? It suggests that they protect you as well. And I guess the reason I ask it is, in framing it as an altruistic gesture, are we encouraging people to think of themselves not so much as at risk and to focus on other at-risk groups?
It's a good question. Probably need to think about that a bit more, but I mean, we do know that the challenge about COVID transmission is that there are people who don't know they have the virus, right? And that leads to more transmission when people are asymptomatic or they're pre-symptomatic before they develop symptoms. So that is the kind of transmission that we're trying to target when we say that my mask protects you. I think. Yeah, it is different when you're in a healthcare setting. You know, there's higher risk. You're actually working with people who are ill, so a different level of mask and protection. But I think with the supply of more medical masks being available, people do have that option if they want to wear a mask that protects them, a higher standard, you know, then they can do that as well.
Thanks. I want to bring Alan into the conversation as well. Just coming back to something you said, Alan, and this may be part of the detail that you couldn't get to in your initial comment, but when you were talking about visitor policy, you were talking about looking very much at the rate of infection in the community as a measure of the risk of someone bringing it in. And I wondered, is there, I think what is really tricky often about all this is different members of the public have different levels of risk, and they may be interested in knowing what is that particular threshold and how is that threshold of risk felt to trigger a policy such as a restriction on visitors. Is that the one that the public would feel is the right one, particularly when restriction on visitors is going to maybe protect on the infection side, but it does have costs that come along in terms of people who are unable to see their loved one, sort of harms to the health of the patient who would be benefited by having the family there to look out for them and provide moral support. So there's always this trade-off, and it's very hard to quantify and capture those other things. So how, you know, if you're looking at the rate of infection in the public, how do you capture all that other stuff?
Well, I have to say, first of all, we are trying to address some of the harmful effects and mitigate against those in other ways. So there are ways to support people accessing the facility, and we've defined. You know, we learned in the first phase that really this idea of essential visitors is is very important for us to define and to not restrict that. The other part is to really focus on you know, at the front door, the screening that goes on that we can do. So we've enhanced you know, the process by which when someone is coming in the facility and visiting someone, make sure that they are not symptomatic, or try and reduce the potential that they've been, you know, potentially someone who could come in who's asymptomatic. So those are two ways we mitigate. The third way we've been mitigating is providing some support in communication channels that using virtual technologies, you know, and communication channels like video calls and things like that. So those are there. So we are very aware of the negative impacts of these types of policies, and really we look at them as being kind of a last case scenario. And you know, really, I have to say it's a very difficult situation. Like, we haven't invoked it yet. We're getting close though, because of what's happening in the community, and also because of the experience in some of the facilities around the region where people are, where we're seeing some outbreaks in the facilities themselves. And you know, we always have to ask ourselves: was that a outbreak that was caused because of someone importing a case in, you know, through a visitor, or did it come because there was a failure of infection prevention control practices in the door? So, you know, we do every time there's that kind of, you know, event has occurred, where we work very closely with Vera's team in trying to pin down the source of that outbreak, make sure we understand where it came from. I guess the final piece is just, is there a number that we use? Is there, and the answer is right now, there is not a specific threshold that we would use, but we would look at those markers that Vera talked about in terms of the, you know, the red zone, or we're seeing right now doubling, you know, in the community over a fairly short period of time. We're seeing community spread. We're seeing cases in which we're not identifying a source for that infection. And so I think with those situations, we have to be pretty careful of what's happening coming into the hospital. And so we're getting close to that kind of approach, and hoping that the mitigation approaches will help us protect the patients and those other effects that you talked about.
I mean, I was looking today at VoxPop Labs COVID-19 Monitor Initiative, which I thought was really useful. Recommended to anyone who hasn't had a look at it. It's ongoing public opinion study monitoring social impacts of the pandemic. And I guess the good message is that public trust remains high in Canada, maybe unlike some other locations. But what I wanted to ask you, as we are now in the second wave, I guess, is there a sort of a structural difficulty that public health policymakers face here? And that could be, I guess, sort of, I'm trying to think of a good hashtag to put on this, sort of, you never know the losses that you avoided. In other words, so what I'm getting at here is that when there's public health measures that are burdensome, restrictive, everyone's going to know the costs, but they're never going to know the downside that got avoided because it got avoided, right? It's a sort of a perennial problem in risk management. Are we having sort of successfully galvanized people to bring down the pandemic, to bend the curve, as it were, in the first wave? Are you thinking we might encounter that kind of difficulty in the second wave? People saying, hey, listen, we did all this and look, it wasn't so bad. Are we?
100%. This is the problem.
Definitely.
Yeah, David Fiskman calls this the paradox of prevention. That
Mm-hmm.
if we succeed, everyone will think we overreacted.
Mm-hmm.
And if we fail, everyone will think we failed. Either way, epidemiologists come out of this looking poorly. And people are always looking back at March and saying, well, the hospitals weren't overrun. What's the big deal? And they failed to understand everything was closed back then. We had a surge of capacity. Flu season wasn't upon us. So we have missed a beat in helping to work with media, frankly, to educate the public about how the situations are different. So everyone's got a role to play, the scientists, the science communicators, public health people, the politicians, and the media. And I want to bring up the politicians briefly because the extent to which public health communication comes from the central political office has been a little broken in this province. I don't want to pick on individuals, but it's frustrating watching things like statements about 36% false positive rates, which is mind-numbingly wrong, coming out of the provincial mouths without any follow-up that is broadly projected. And so it comes down to a handful or a community of independent scientists and educators to correct misinformation spouted by public health leaders. We should not have that crisis in place. And the focus right now should be exactly as you place it. The focus should be on convincing people of the need for the restrictions and telling it about the things that we avoided successfully. These are success stories, by the way. March was a success story in large part. And somehow that success story has been lost in the narrative. Instead, it's all about the suffering caused by the economic restrictions.
Mm-hmm. Vera and Alan, do you want to weigh in on that?
Yeah, I would agree 100% with what Ray just mentioned. We do have a tough situation right now in the sense that we have this perception, and it's fairly widely perceived that there was an overreaction in the spring, and overcoming that is quite difficult. And the number of cases going up right now. And we can predict that on its current trend what's going to happen, and we're not preparing for things the same way we did in the spring. It's quite clear that people feel a little less willing to shift and change because they feel that we'll be able to just get to where we needed to go like we did in the spring, and we see that happening in the hospital. We see that happening more broadly around the community.
Yeah, I'm concerned because I think the tool we used of shutting everything down in March is too harsh. I think people have lost their life savings. People have lost their jobs. And I don't want us to go back to that. People will be, much, much worse off building from this low point if they have to go through another, complete shutdown. And so, I mean, this is what I'm trying to say is we as a population can avoid that it actually was our individual behaviors, each of us adding up, that led to the virus coming under control in the first wave. And we can do it. It's within our power to do it again. And it allows us to avoid those more harsh actions that were taken. You know, we have the knowledge. We know if you stay 2 meters away from somebody and you wear a mask indoors, you are unlikely to pick up the virus. And maybe that seems too simple. I don't, as part of it, but also the idea that it adds up, right? We don't have to be perfect, but if enough of us do this enough, that is actually, you know, what we have. And, you know, I was thinking of the data. I haven't seen actually province-wide measures about those things, right? We collect information here in Ottawa about how much are people physically distancing, you know, from others indoors, how much are they wearing masks, but those are the key leading indicators that will tell us what are we going to end up with. And you know, it's important to have that information to be able to do the prevention work. I think the other piece that shows us what was achieved in March is the modeling. Right? We actually developed very predictive models adapted to Ontario variables, and we can say where things would have gone. And we still have good models that are showing us where things can go. And so being able to use that information, again, sharing it with the public, you know, making it clear, you know, that is one of the tools we have. And I'm also interested in new ways, like what are the new things we can share. And so one of the things I like to look at now is the sewage water, you know, samples that have been collected and measuring virus in the sewage in Ottawa is kind of a new measure that allows us to get past the criticism of, oh, well, cases are just going up because you're testing more, or, you know, different criticisms around that. It's actually just measuring the virus that is out there without any of us doing anything. And it's very correlated to other measures. And it's in real time. It doesn't lag behind the getting symptoms, getting tested, getting your test results. So I hope, you know, some of these variables we can use and use new data sources also to make a new message to the public about the importance of our individual actions.
And so those are great responses. Thank you. I want to sort of add in a question, sort of in the spirit of this idea. How do we deal with oh, nothing bad happened, therefore we don't need precaution kind of reaction, or it wasn't so bad, therefore we can all relax. One of the questions coming in from the audience is, what can we learn from the second wave in Europe? And I'd amplify that with my own question, sort of along the same lines. Are there counterfactuals out there we can use to show this is where we could have gone, and this is where we most likely were going to go, and here's how that compares to where we ended up with?
Well, I'll take a first shot at that. Of course, the model in Ontario was based on Australia, Victoria, which was the worst case scenario for a comparable size population to ours. And, you know, the best case scenario were places like Sweden, one could argue in some ways. But the problem is, from a messaging standpoint, is that we are outshouted by those who cherry pick certain narratives from around the world. And we're outshouted because they have a more passionate vested interest in telling a particular narrative, and we're busy doing other things. You know, and it's really frustrating. For example, the Imperial College model by Neil Ferguson is widely dismissed by the COVID denial population, and it's shat upon quite vividly and consistently by people, but it was pretty good. It actually predicted things fairly accurately. We never tell the story of how accurate it was and how much suffering was avoided because it was accurate. We let this other side run with their narrative unopposed to a large extent. I understand why. Who's got the time really or the resources to combat this? So I think it's important that we enlist the participation of media to get on board with reframing the history, the recent history, in more factual terms, and not to let this particular cadre of individuals define the narrative incorrectly.
Yeah, that's interesting. Personally, I would agree with you, Ray. I don't have a lot of extra time to go back and try to change the story, but I see the value. I mean, the other challenge I think we have as public health is it could be seen as self-promoting if we talk about what was achieved, you know, as public health service for, you know, responders. So, you know, I think there's other voices have to speak to this. Yeah.
Yeah, that's a good point. Another question here, it's just I love the optimism in this question, which is, what new data points are public health authorities, whether hospital or Ottawa Public Health included, collecting because of COVID that will continue to be collected post-pandemic? What data gaps have you identified?
Sure, it's Vera. I can start. I mean, I think some of the information about individual socioeconomic status, that will continue, and that's excellent. And it's been created, how we ask about this, it's been created with community that, identify as wanting the data, but wanting it collected in a way that is not going to stigmatize, not going to label and cause more challenge. And so this has been a good process. I think some of the relationships with community members, African, Caribbean, Black, First Nations, Inuit, Métis, it's been very helpful to think about how we maintain, these kind of variables in data collection. I think the other information that's grown is some of the mapping information. So it's reinforced the value. People do like to see information on a map and know about where they live, and so we've gotten to the point where we're using the Ottawa neighborhood study, which had a lot of rich information about the different neighborhoods in Ottawa, and have been able to add in COVID information. And so I think that's something we hadn't done previously with public health, infectious disease data, or so I could see us continuing to build on that collaboration with the Ottawa neighborhood study for more public health variables. I'll just leave it at that for now. Yeah.
Okay.
And so I'll add a bit to that, because I think there's some other parts of that story I think are relevant, which is the clinical data that we obtain through our electronic medical records that can then be used to complement our understanding of disease and the impact of disease. And of course, so as an example, we can track people's symptoms at the time of testing, or we can track their outcomes after they've had a positive test, and track the natural history. But then that can then also be used as trajectories combined with some of the information that Vera talked about in terms of neighborhoods and populations who are at particular risk. For that to actually be useful, we do need to have access to the electronic medical record data. It also has to be compiled and used and put in a way that can be accessible to researchers, as also the analysts that we have employed with us. But the other part that has to happen is we have to integrate it across the different sectors and different providers, so that we can have one single version of a patient's journey or person's journey through time. And that, we have seen more collaboration amongst the partners across the region. I think that's another sort of positive thing, is that there has been more discussion and more interaction about how we could support that. But it does need to go further than what we've done up till this point, and to make it actually something on an ongoing basis we can use, will probably will take some changes in how legislation works and how we're allowed to share data amongst different players.
Thank you. I think we have time for one more question from the participants before we close at 8 o'clock. And the question is, the federal government and some provincial governments, including Ontario, have launched a contact tracing app. And there's been reasonable uptake of that. In your view, have there been beneficial outcomes from that app?
I think my sense is it's too early to tell. We haven't seen an evaluation per se. We have seen people presenting to our centers with a positive like a flag on their app. We can go back and evaluate. I remember I was saying we can evaluate impacts, to see the positivity rate in those groups, and to see. But just because someone's positive with an interaction like that, it doesn't mean necessarily that the app is, or sorry, let's say if they're negative with a positive contact, because as Vera mentioned, this issue of the personal behaviors and how that shapes whether a close contact is going to lead to you getting infected is very, very important. So to a certain extent, it may be something that is very difficult to evaluate. I'm not sure if Vera or Ray has an idea about how to design the study to determine the impact, but I do think that's an important policy question that needs to be answered.
I want to have a comment about the app as well. First of all, I don't think the uptake has been great. I think we need, more than half of the people to use it for it to be really impactful. Any number of people using is good, but we need like 60, 80% to make it really effective. However, I will say that the app represents the epicenter of every conflict surrounding this epidemic. It represents everything because it's a really good tool for public health to use to control the epidemic and prevent closures and things like that. But it does offer at least the appearance of privacy implications. And that is everything that the COVID denials hate. So if you could design a particular tool that would create more divisions in society around this epidemic, it would be a COVID tracking app. That's what we've done. Even though this one is pretty darn good, it doesn't impinge upon your privacy at all. It's just perceived to do so. It just makes our job just so much harder. It's exhausting even thinking about it. That's all I got to say.
Yeah, I don't disagree with either Alan or Ray. I would add that we know from public health, science that you have to make the healthy choice, the easy choice, right? Like you have to decrease the barriers for people to adopt something new. So, I'm not sure we've done all we can to make it easy to take up the app and use it as well. I think that's something we could do more on. I also think it's interesting. It's an example to me of how people are looking for a technology, they're looking for a medication, they're looking for a rapid test, and all we have to do is stay 2 meters away from most people outside our household, right? Like there is something also there about how it is almost too simple and yet too hard to keep 2 meters away from others, right? So I think we've learned something through this pandemic about how important social connections are. And that's really, really valuable. Again, I will never say that people must stay to their household if they're a single person or they're an isolated adult like that. That is too much. People need each other for their health and to live well and their well-being. So anyway, I guess maybe that's a funny place to stop, but just going back to the power of the individual and what we can all do, it certainly is. It is possible. We can change the data. We can change the trajectories, right?